Hello, Feral Animals Corps, and welcome back to FLVAC Trainings, Episode 8, Anaphylaxis. I'm Dr. John Barr, and I'm going to take you through it. As per usual, let's take a few moments to read through the disclaimer. All right, let's get into it. So, happy spring, everyone. Hope you guys are enjoying the weather. This is what kind of inspired this talk, because now you're going to start to see people spending a lot of time outside. They might encounter insects like these bees, after which they can get stung and go into anaphylaxis. So I thought it would be a good time to review anaphylaxis. So what actually is anaphylaxis? Anaphylaxis is a life-threatening allergic reaction. Life-threatening allergic reaction. And if you don't treat it, it can progress rapidly to anaphylactic shock. Remember one of our earlier episodes we talked about types of shock. And it can ultimately lead to death if left untreated. So really important that you recognize this and that you treat it. 1/2 of the fatalities due to anaphylaxis occur in the first hour. Because of that, this is incredibly time sensitive, and because of that, it means that you as an EMT can influence the outcome of this by acting quickly. This is somewhere where EMS can really make a difference, because getting epinephrine in the patient sooner is going to help them a lot. Okay? Now, what are the common triggers for anaphylaxis? I alluded to bee venom as one. That's the general group of insects called the Hymenoptera. That includes bees and some others. As you can see here, there's a lot of things on this list. A lot of different foods. Nuts, shellfish are probably pretty common, as are some of these others. You can see some of the meds here. So beta-lactam antibiotics, those are your penicillins. ASA, or acetylsalicylic acid, that's aspirin. Trimethoprim, sulfamethoxazole, that's a sulfa antibiotic. NSAIDs are things like your Motrin, ibuprofen, naproxen, Aleve. Vaccines, latex. There are many things that can trigger anaphylaxis, and to be honest, this list is nowhere near exhaustive. There are many more things that can cause it. Now, how are you going to know when anaphylaxis is present? In general, you're going to have two things. One, some sort of exposure to one of those things on the previous list or some other thing, although in some cases the exposure isn't known, so you really have to use your clinical judgment. But then here's the key part. The key part is you have to have 2 or more body systems involved to meet criteria for anaphylaxis. So if I put on a latex glove and I get a rash on my hand, but that's it, that's just an allergic reaction. That's not anaphylaxis. If I put that on my hand and then I start to have a rash and I'm having a hard time breathing, or I have a rash and I have stomach upset, once you get that second system involvement, then it becomes anaphylaxis. And it's not always difficulty breathing. Okay, I think the most commonly missed is people dismiss it as a stomach bug. They eat something they're allergic to, they get upset stomach, dismiss it as a stomach bug, and don't notice they have some little hives on their back. That actually could be anaphylaxis, so it's really important to recognize this. Now, I mentioned you need at least 2 body systems. How are the different systems involved? So ENT, ear, nose, and throat. Sometimes patients will describe a sensation of throat fullness. They just feel like their throat's full. I've had many patients tell me that. That's about half the time. Wheezing, respiratory distress. I think this is commonly mentioned in school, in EMT school, and other places. Very common as well. As is pharynx, which is the back of your kind of mouth and throat, and larynx, where your windpipe is, and your vocal cords. Those can be swollen about half the time. Rhinitis, runny nose, things like that, also very common. Now, hypertension, if it progresses to hypertension, you're a little bit behind the 8 ball. I mean, this can happen rapidly in minutes, but if the patient's hypertensive already, you need to get epinephrine in ASAP. Chest pain is also possible in anaphylaxis. I mentioned rash on the skin, so that's urticaria or hives, the most common rash. Also, you can have angioedema, which is swelling. Flushing or looking a little red, also very common. And I can't emphasize enough GI symptoms: nausea, vomiting, diarrhea, stomach cramps. These are all part of anaphylaxis. It's a very common presenting symptom that I see, and I think it often can get dismissed as a stomach bug or something else. So you really need to pay attention to that. If they say, oh yeah, I got stung by a bee and now I have nausea and vomiting, or sometimes they say, yeah, I don't feel good, I have nausea and vomiting, I got a little rash on my arm. They may not remember getting stung, so it's important to think about this as a possibility. Now, I don't want you to overthink it because not everyone who has a stomach bug has anaphylaxis. But, if the story adds up, patient ate a cookie and now their stomach is upset and they've got a rash, think anaphylaxis. Okay, if there's two systems involved, think anaphylaxis. At least think about it, and see if you need to give the EpiPen. Okay, really important to recognize some of these more atypical things. Anaphylaxis overall is probably underdiagnosed and undertreated in general, so keep this in mind. Now, it can also involve the neurologic system. Headaches, seizures are possible. Again, not as common as the other stuff. In most of the cases I see, it's stomach upset, it's rash, and it's respiratory and ENT. So that fits with the statistics here. So very common stuff here. Now, how do you treat it? So step one, as you can see in the photo on the left, is take away the allergen. So if it's a bee sting, get the stinger out. If it's something you can remove from the patient, like a latex clothing, latex, glove or something, take that off. Then you're going to apply high flow oxygen, and you're going to give epinephrine intramuscularly. This photo happens to show the EpiPen. There are many other brands. I don't have any financial conflict of interest. I don't get paid by the EpiPen brand, but that's one common device to administer epinephrine that you can use. So now, who do I give it to? You're going to give it to patients with anaphylaxis. Who has anaphylaxis? They have exposure to an allergen plus 2 body symptom involvement. Who is it contraindicated for? Essentially no one. So there's no true contraindication, no absolute contraindication to epinephrine in a true life-threatening emergency. Okay, so if they truly have anaphylaxis, there's no contraindication. Okay? Now, how do you give it? So you're going to grab the auto-injector. Notice how this guy's grabbing, he's not putting his thumb over the end. That's good, okay? And you're going to inject it into the mid to lateral aspect of the thigh, okay? Now, what I see, people think you have to stab it in like a sword. You don't, okay? You don't need to take it and stab it. You just need a little bit, just press it firmly into the thigh, and the spring-loaded part of this will shoot the needle into the leg and will inject the medication, okay? You don't need, to wind up, with a very pronounced stabbing motion. You just need, half inch or so, press it into the thigh and press firmly, and you're good, okay? For an adult, the dose is 0.3 milligrams intramuscularly, and that can be given every 5 to 15 minutes. For a child, it's 0.15 milligrams, so half, can also be repeated every 5 to 15 minutes as needed. Most people will respond to the first dose. Occasionally, you'll need the second dose, and by 3 doses, almost everyone will respond, but there are cases that can be refractory. So it is important to know that because they may need additional epinephrine infusions or other things that you're going to need ALS or an ER for. So it can happen, but most people respond in 1 to 2 doses. Now, what if you're saying, well, doc, I don't have a scale. I don't know exactly how much the kid weighs. If you're a little bit off, and they're 55 pounds, it's not a big deal if they get the adult dose. In general, most grade age children are going to be about 66 pounds. So, if you can always also give a second dose, that will make the full adult dose if you think you're underdosed. But in general, if they're approximately 50, 60 pounds, you should give them the adult. You can give them the adult size. Okay. All right. So that's how you give the epi. Now, I mentioned before calling ALS. So there are a lot of other adjunct therapies to anaphylaxis. The single most important is epinephrine, which you guys can and should give. You can also give steroids, H1 blockers, H2 blockers. H1 blockers are things like diphenhydramine, also known as Benadryl. H2 blockers are famotidine, also known as Pepcid. IV fluids, and albuterol can actually be given for refractory wheezing as well. Now, these patients, you should call ALS, but again, do not delay transport to the hospital. Now, let's look at this for a second. Which of these type of exposures is worse in terms of anaphylaxis? So if you get exposed to a latex glove, or if you eat a peanut butter ice cream and you're allergic to peanuts? The one with the ingestion of the peanut ice cream is going to be worse for you because now that thing is in your system. The latex glove we could take off, right? And we can remove the exposure. Once you eat the exposure, if it's a food like a shellfish or a peanut ice cream or something, that's in the system. And the risk of rebound is much higher with that because the allergen is still there. Now, because of the risk of rebound, meaning they could go into anaphylaxis, start to improve, and then get worse again, you really need to take these patients to the hospital. And they may be tempted to try to refuse. If they do, you should really spend a lot of time explaining the risks and benefits because this is extremely life-threatening, and the medical advice, the medical recommendation will be that all these patients who receive epinephrine should go to the hospital. At a minimum for monitoring, typically we'll monitor these patients in the ER for 4 to 6 hours before discharging them. We also make sure they have a prescription for a new EpiPen and other medications and stuff to really kind of treat this. But it's really important that you encourage these patients to go to the hospital, and just know that if they ingested the allergen, it's a lot worse because it's still in their system. Like I said before, take them to the hospital, okay? If they're trying to refuse, consider calling medical command. Really explain to them that anaphylaxis is a life-threatening emergency, that it can get worse in the order of minutes, that it can lead to death, and that they need to be monitored because if they start to react again, they need to be able to be given more epinephrine, more medications, and in severe cases, they may need to have their airway managed. Although I think now with giving epi and getting your medication on board, that's fairly rare, but it could happen, and they need to be in a place that can handle that. So with that, feel free to reach out to me with any questions. Hope you guys enjoyed this video. Hope you found it helpful. This is a reference to one of the emergency medicine textbooks if you want to take a closer look. And with that, I'll see you guys in the next one. Take care.